Yeah. So starting with the simpler cases, the epiretinal membrane removal with the forceps. First to the basic steps, truncation of the posterior vitreous cortex. It is better not to do a forceful PVD because sometimes it is attached with an epiretinal membrane which can cause iatrogenic break. So we need to take care, we need to do a meticulous vitrectomy, and there is different techniques of removal of the epiretinal membrane: segmentation, delamination and peeling. Peeling with the forceps and picks is better to be avoided. In this case it was a small membrane, so it came off very easily. And then doing a good laser to prevent the rebleeding. And this is what we are telling, that it is better to avoid the peeling with the membranes and picks because it leads to iatrogenic break. So this is a video what we should not do after removal of the vitreous hemorrhage. We can see there is a bad tractional detachment in the nasally. Generally the nasal detachments, tractional detachments are bad. Try to remove with a cutter, but the membrane, the plane was not very clear. So try it with the forceps and this resulted in iatrogenic break. So removal of the membranes, the less we use the forceps and picks, it's better. Ideally we should do segmentation and delamination either through the cutter itself, or we can do a bimanual dissection in complicated tabletop detachments. As in this case, you can see the tabletop detachment is quite severe. The posterior posterior pole is involved. After doing the vitrectomy, we are trying to find out the plane. Got the plane with the with a cutter and trying to peel, and then perform the delamination, which is the conformal cutter delamination. Now we are sure about the plane, so delamination becomes easier. Once we are through with the entire membrane, putting triamcinolone again, because a lot of cases there are vitroschisis, removing the remnants of the vitreous, and there was a little bit of puckering in the posterior pole, so stained with the BVG dye and did a ILM peeling. Sometimes still we need to do a bimanual technique because the fibrovascular membranes are so severe. We need to put the chandelier slide. You can see it's quite bad. Now with the forceps, we need to cut this membrane with a very small snips of the scissor. Curved scissors. Make sure that we are in the proper plane. Either we can do an inside out delamination or outside in delamination. Depending on the situations, you can see the small snips we are giving to separate the membrane from the underlying retina. Now the entire membrane we have removed. Take it off with a cutter. diaphragmize the bleeders and do a good laser. Now sometimes we can use the machine, newer technologies like proportional reflux to find out the membrane. Sometimes the nasal TRDs are so bad that we need to use the proportional reflux as we are using in this case, putting fluid inside. As you can see the animation, we are putting fluid inside the membrane, in between the retina and the membrane, and thereby creating a plane. Once we get the plane, we can segment it. Now we have a plane. We are segmenting the membranes in small pieces so that it will be easier to delaminate those areas. Now this is a fold back cutter delamination. You just hold the cutter over the membrane. Diathemize the bleeders. The last scenario is a combined retinal detachment and the tractional with the reg RDs, which are sometimes very difficult to tell. You can see the detachment is quite bullous. We can see the break superiorly. Once we get rid of the vitreous in the posterior pole, marking the breaks, as it is quite bullous, to take care of the peripheral vitrectomy, we put PFCL to stabilize the posterior pole. Once we stabilize the posterior pole, we are taking care of the vitreous, the peripheral part. You can see the subretinal fluid is coming out and retina is settling. Now draining the subretinal fluid and settling the retina. So the take-home message with the newer technologies, the better fluidics and the curved scissors, use of proportional reflex, now we can give a more predictable outcomes in very bad TRD cases. Thank you.